So as Bhavan said, I'm a consultant uropathologist in Newcastle, in the northeast of England. I'm very lucky to work in that department. I've got very supportive clinical colleagues, and if there's one piece of advice I could give to you all in your careers going forward, do not underestimate the power of good relationships and good communication between clinicians, radiologists, pathologists, and everyone. It really does make a very big difference to both you and ultimately your patients. So if there's one thing you remember me saying, just remember that thing. Okay, so I've been tasked with talking about the pathology of prostate cancer. I'm going to attempt to give you a bit of a broad overview, and with a bit of emphasis on what I think are the most clinically important points. So in the next 10 to 15 minutes or so, I thought a very quick reminder of the pertinent epidemiological and etiological factors, just to provoke a little bit of thinking. I'll do a quick run through the methods of tissue diagnosis, then a few words about histopathology, touching on some important histological factors and some of the important histological variants which you should probably be aware of. What I will concentrate mainly on is what exactly Gleason grading is, what it means and how it's evolving. And then I'll end on a few words about pathological, prognostic and predictive factors, and a little bit on staging. I hope that what I'm saying is probably going to be echoed throughout the day with the other speakers, so they should consolidate anything that I don't cover in a lot of detail. So the main reason for going over the epidemiology is just to remind us all that prostate cancer is extremely common, and of course that means that it has a large effect on health systems globally. The incidence and mortality rates are very variable across the globe, and this is probably linked to the fact that a lot of countries have adopted PSA serum screening, and that we have a lot of earlier detection and improved treatments. There's also variation in documented risk factors, which include things such as obesity and high dietary fat and decreased physical activity, which is obviously very variable across the globe. And of course, there is a very strong relationship with advancing age, not least because we still do find a lot of incidental prostate carcinoma both at autopsy and in sister prostatectomies done for other reasons in elderly gentlemen. And of course, there's also proven genetic susceptibility as well, which I won't go on anymore to, because that could probably fill a whole week's worth of seminars for you. So moving on to some more practical pathology points. Obviously, pathology assessment requires some tissue. The patient pathway to their diagnosis and therefore their treatment can involve one or more of these methods of tissue diagnosis. So of course, the most common is the needle core biopsy, and they're undertaken usually in gentlemen where there's either a clinical or a radiological suspicion of malignancy. One of my colleagues is probably going to very eloquently talk about the different types of needle core biopsies later on, so I won't dwell on that for any longer. I've just added transurethral resection biopsies there as well, just to mention that although they're not a primary diagnostic procedure, they do undergo pathological sampling due to the known incidence of clinically inapparent disease, especially in older patients. And then of course radical prostatectomies, which provide a final diagnosis, grade and stage, and stratify the patient prognosis and guide any subsequent treatment and follow-up. Okay, again, I don't want to dwell too much on the ins and outs of actual histopathology, because I'm the pathologist. I don't want to teach you to do that, otherwise I'll be out of a job. But I just did want to mention that when we get needle core biopsies from prostates, we examine them all. We examine all the tissue that's submitted, and we also examine it at several different levels of tissue, and that's because of the nature of prostate sampling. Although there obviously is a move to more targeted sampling, which I'm sure will be talked about later by my radiology and clinical colleagues, the sampling of prostates is still that. It is sampling. We're not targeting a definite lesion that we can definitely see. So therefore, the tissue in the cause may well have missed, or may well have only caught the edge of any tumour that is there. So that's why we often report things like ASUP, so atypical small acinar proliferations, or high-grade PIN. And obviously there are things to do with that change the way that you treat the patient. Again, similarly with radical prostatectomies, the prostate cancer is often, even when we slice a prostate, we still can't see it. It's not grossly recognisable, therefore we need to look at all of the tissue. We embed all the tissue from radical prostates, so it's not a small amount of workload. We look at a lot of prostates. Yes, takes up a lot of my time, but I of course love it. I just wanted to share this quote that I actually read quite recently. I'll let you read it yourself. It's from the World Health Organization classification of tumours, and I think it very nicely explains quite a fundamental concept of histopathology, and that's to say it's very much an opinion, albeit an educated one. And I guess the point I'm trying to make is that although we are classed as a laboratory specialty, it's perhaps better to think of us more like your radiology colleagues, other than your blood science colleagues, because what we're giving you is an opinion, as opposed to an absolute answer. Just something to bear in mind. Obviously, we use that morphological expertise along with things such as immunohistochemistry and consensus opinions between all of us to reach what we hope is a diagnostic accurate conclusion for you and the patient. So this is what I really wanted to concentrate on, Gleason grading. So Gleason prostate cancer grading system is used worldwide. It was first developed in the 1960s by Dr. Donald Gleason, and it differs to grading in other types of cancers, mainly because it's based solely on the architectural pattern of the tumour that we see down the microscope. And secondly, and probably most different to other cancer sites, is that we express it in quite an interesting way. So we express the degree of differentiation of prostate cancer as a sum score of the two most common morphological patterns that we're seeing down the microscope. That being said, it's still essentially just giving you a quantification to the degree of glandular differentiation in the tumour, with 1 being the most differentiated and 5 being the least differentiated. I should point out at this point that the groups 1 and 2 from Gleason's original work are pretty much obsolete in modern diagnostic terms. I wasn't going to dwell too much on talking about tertiary grades because it's a little bit confusing for us, and I think the simplest thing is to just think about the Gleason grading as the 2 most common grade patterns present. Okay, so we still use the same basic histology patterns that Dr. Gleason described back in the 1960s to assign our morphological grades. However, the International Society of Urological Pathologists has modernised and revised this a few times. Most recently in 2005, there was a change of some of the groups from 3 up to 4. So some of your gentlemen that used to be a 3+3 may become a 3+4. And then perhaps more importantly, in 2014, there was the introduction of the prognostic grade groups. And this is another important point. The grade groups were introduced for a variety of reasons. The main reasons were for clinicians, and that was to simplify the risk stratification and the categorization groups into 5 rather than the traditional 12 different groups that the sum scores would produce. And then perhaps more importantly than that, what it does is it separates out the Gleason 7 groups into 3+4 and 4+3, which could potentially be cancers that, although they are both scored 7, might behave incredibly differently. And then also, perhaps even more importantly for that, the grade groups were also designed for the patients themselves. as a communication tool. If you're telling somebody that they've got Gleason 3+3 equals 6 cancer, then they think that there's 5 more groups that are better off than they are, whereas actually we know obviously they've got a lower risk and probably very indolent cancer. So actually calling them grade group 1 sounds appropriately more low grade. So just to reiterate that point with some helpful traffic light systems, we've got the old system there on the left giving your Gleason sum scores, and then your new grade groups on the right there. So obviously very important and a lot more simple. This is just going to lead me on to talking a little bit more specifically about pattern 4, which is the most important pattern because it's kind of like the moderate and the intermediate grade, which is where possible ambiguity or difficulty in knowing how to deal with might arise. There are quite a lot of studies that have looked into the different morphologies of pattern 4, and they all seem to agree that the presence of a cribriform pattern infers a worse prognosis. In fact, if the presence of cribriform pattern 4 is associated with increased distant metastases and is an independent predictor of disease-specific death. So obviously it's probably very useful to have that mentioned in pathology reports. And also, even though we've managed to separate out those 2 different Gleason 7 groups into grade group 2 and grade group 3, especially within the grade group 2 cohort, so those are the 3+4 groups, it was probably very useful for you guys to know exactly how much pattern 4 is present in there. There's been quite a lot of studies that all agree that if there's less than 10% pattern 4, then that patient may well be better stratified into the low risk group rather than the intermediate risk group, obviously in the absence of any other risk factors like increased PSA or staging on any imaging. I very briefly wanted to touch on 2 important histological variants. Basically everything that I've been talking about so far is about microadenocarcinoma, which is by far the most common. But there are 2 types that are worth mentioning, and those are intraductal adenocarcinoma, which although rare is a very important and significant finding to share with you. You usually don't see it on your own. It's usually combined with microadenocarcinoma. All of the experts don't agree exactly on its etiology. The preferred theory is that what it actually represents is high-grade microadenocarcinoma that's managed to retrograde, spread and grow back along native ducts. Therefore, it looks like it's an in situ, where actually it's invasive that's grown back. And then there's a second theory that it's actually an in situ precursor directly to high-grade microadenocarcinoma, which is different to the sort of the high-grade PIN in situ theory. It is associated with adverse findings at time of radical prostatectomy, such as a high concurrent Gleason score in the microadeno variant, large volume, high stage, and it is actually an independent predictor of clinical outcome. At the moment, we don't actually give it a Gleason pattern, so it's entirely plausible that you could get a core biopsy that has microadeno 3+3 and some intraductal. The Gleason score at the bottom of the report will still be 3+3, but you need to take note of the fact that intraductal carcinoma is present in there, because that is a high risk feature, and I would argue that that should increase the patient should be put either into the intermediate or even the high risk group. And then quickly, just ductal adenocarcinoma, which again is it's a subtype of prostate cancer which has a distinct morphology when we look down the microscope. We very rarely see it on its own. It's usually in combination with some usual microadenocarcinoma, but again, it's more aggressive than your normal tumour for the reasons which are outlined on the slide and that you can read for yourself. For whatever reason, we do give this a Gleason score, but it gets a Gleason score of 4. So it is reflected, it will be reflected in the final Gleason score if this is present. That you need to be thinking about either intermediate or high risk stratification if your patient has this. So I just want to finish off with some prognostic and the pathological prognostic and predictive factors. So factors based on core biopsies or any incidentally cancer found in your TURP specimens will predict any histological findings in any subsequent radical prostatectomy specimens. Therefore, it allows for risk stratification and treatment and follow-up planning. By far the most important of these, and this is why it's included in your risk stratifications, it's the Gleason score. And that's used to predict post-operative stage, tumour progression, and prostate cancer specific survival. Therefore, it plays a pivotal role in the treatment decision. The amount of cancer in needle core biopsy will correlate with the pathological stage and patient outcome, and that's why we will report the proportion of tissue involved. There's a lot of variation in how this is done, both throughout the United Kingdom, throughout Europe, and throughout the world. Some people will give a linear extent, some will give a percentage volume of the amount of cancer versus benign tissue, some will just give you the number of involved cores. The method doesn't really matter as long as sort of you have a locally agreed protocol and you know what each other is doing. And then other factors such as the presence of adipose tissue invasion or seminal vesicle invasion, which you can sometimes diagnose on core biopsies, and the presence of perineurial invasion are also of prognostic significance. For completeness, here's a list of the pathological factors which are of significance when we assess radical prostatectomies. Again, good old Gleason grade is the most useful prognosticator, followed by pathological stage. It's well documented that spread beyond the boundary of the gland is associated with a higher rate of recurrence. There's debate about whether quantifying the amount of extraprostatic spread is of enough significance to predict rate of recurrence, but we will report it. Then surgical margin status, which I won't talk about too much because I don't want to upset anyone. It is a predictor of biochemical recurrence following radical prostatectomy. And again, reporting the extent of a positive surgical margin is linked to outcome, so we will report that as well. Tumour size, again, like the amount of cancer in cores, this is very variably assessed and reported by pathologists, but it is of prognostic significance, so we will try and give you an idea of what proportion of the prostate is involved by disease. And finally, perineurial and lymphovascular invasion. They have less established evidence, but they're still reported. I'm not sure if anybody else throughout the day will talk about the staging, but just a final slide, if you will, to remind you of the pathological TNM staging. In the UK, we use the UICC 8th edition, but obviously there's the AJCC, which may well be used elsewhere. But it can basically be summarised as PT1 is clinically inapparent, T2, it's confined to the prostate, T3, it's either just managed to sneak out of the prostate and go into the seminal vesicle, and then T4 is when it's managed to get into adjacent structures. And then nodal and distant Mets are either there or not. It doesn't matter how many of them there are. Okay, so a bit of a whistle stop through it. Hopefully I've given you a bit of an overview and sort of dwelled on some of the more clinically relevant or important points. So thank you very much for your attention.